Welcome to the Dr. Paul Show. I want to talk about a subject that's near and dear to my heart. I love talking about this subject because it's a more difficult subject to treat, and I love the challenge of treating bipolar disorder. And there's some pretty scary statistic I'm going to share with you in a moment. Well, actually, let me share it with you now, actually, because this is going to put things in perspective. It takes the average of three to four doctors. That includes psychiatrists, family doctors, 7 to 10 years to diagnose this condition. Think about that. Would that be acceptable in any other area of medicine? If it took 3 or 4 doctors this long to diagnose diabetes, hypertension, cancer, we don't see anything like this in any other area of medicine that's even close. So why does it take this long and this many doctors to diagnose one psychiatric condition? Well, the reason for it is this. When we think about bipolar disorder, we think about the most extreme variation we call mania. So mania basically is when the mind is very irrational, paranoia, grandiose thinking, rapid speech. If you've ever been around someone who's manic, you can definitely pick it out. And so that's we call mania. But that's only about 10% of the bipolar disorder right there, 10%. And that's the classic version. Bipolar 2 disorder, it's mania, but also with depression. Usually, not every time actually. There's some bipolar 1 patients who don't get depressed. Bipolar 2 disorder, which is what we call hypomania. So hypomania, I call mania light. It's not as bad as mania. The mind is still going faster than usual. You don't need much sleep. Most bipolar 2 patients maybe get 4 hours of sleep, but they feel great the next day. Most people who get very little sleep like that are going to feel terrible the next day, right? But these people don't. No, they can get 3 or 4 hours. They're good to go. The manic patients, bipolar 1, they may not sleep at all. They might go nights without sleeping, or maybe a week or so without sleeping, and function okay, or they think they are. And I learned this years and years ago. I went to speaker training to lecture doctors about a medication called Seroquel. And it was basically indicated at the time for bipolar 1 disorder. But then they shared in the breakout session, because we were trained to talk about the slides, and they're kind of training us to talk to doctors about it. And then they shared this with us at the time, and I asked the person there, the doctor that was speaking to us, I said, well, it's indicated for this, but how about this? Why can't we talk about these 2 things? That's the majority of it. He goes, well, we can't talk about that because it's not indicated for that, so we can't talk about it. And I said, well, yeah, but that's 9 out of 10, and they, nope, can't talk about it. And that's the way it is with the FDA. When medications come out, they can only talk about what they were originally indicated for. Otherwise, we call off-label, and off-label means using medications for other reasons that it wasn't indicated for. And the FDA will not allow any off-label talk or information with lectures, and if they catch you, you get in trouble. So basically, the guy wouldn't talk about it. But it started my thinking this was many, many years ago. I don't know, maybe 20-some years ago that this happened. And then bipolar NOS. So basically, bipolar NOS is not otherwise specified. So in other words, it doesn't fall in 1 or 2. So who are all these people? Almost 3/4 of people with bipolar disorder are NOS. These are people that don't have mania, they don't have hypomania, but their mood is up and down. They have mood swings. They get the key feature with NOS patients is depression. And so what happens is when they see a doctor and the doctor takes a history, if you don't have mania, they don't see it as bipolar disorder. So they think it's just regular depression. Sometimes they'll catch hypomania, maybe, but oftentimes they don't catch that because they think it's just anxiety that's not actually hypomania, so they'll miss that too. So 9 out of 10 typically are missed by doctors. That's where this comes in. The reason it takes this many doctors this long is for this reason right there. And 20, 25 years later, it's still the same. Nothing's changed. I see it all the time in my practice. I see people coming in, take their histories. They've been seeing doctors over the years. And I'm just shocked and amazed that doctors haven't stepped back and think, like, why do we keep beating a dead horse here? Why do we keep doing the same thing over and over again, expecting a different result? That's the definition of insanity. Because doctors just can't think. They can't think bigger. They think, well, this is. In other words, when people are 1 or 2, they're out, they're having fun. They might, they don't want to be brought down because they like the way their mind is. They're getting more done at work. They're out competing other people at work, so they don't want to bring that down. The mania might be caught if someone does really crazy things, like running naked through the streets and making a scene, and that gets arrested. And there was a guy who, a patient of mine, who they caught him because he was at a mall, and there was this statue of a horse there. There was like a big bronze thing of a horse. Well, he ended up getting on top of that horse and was riding the horse and screaming and yelling, and they finally called the police on him, and he was in mania. So it's easy to spot mania, and that's what. But again, doctors, when patients come into the office, they're depressed. They don't. That's what they come in for. They come in for depression. And the problem with doctors is that they don't. Many doctors just don't take a good enough history. You have to go back and say, okay, you're depressed now, but talk about a month ago, a year ago, 5 years ago, 10 years ago. Tell me what else has happened. And if a doctor doesn't ask the right questions and ask and think about, well, have you ever this? Have you ever had irrational thinking? Have you ever had nights and weeks without sleep? And if you don't ask those questions, you may miss it completely. And most doctors rush people through in and out. They don't take the time with patients to take a good history. That's typical doctors. And so the problem is this never gets treated. So what happens then? They give them an antidepressant. So what does that do? It can make them worse. Well, an antidepressant with these people, it does one of a few things. It either makes them worse, makes them, if they're depressed, and then you give it to them, it makes them manic, because that's what antidepressants can do in bipolar disorder. Or they don't work. They don't do anything, or they get people partly better, but then the doctor is wondering, like, why is it not working as well as it's supposed to be working? Did they not read the manual? Did they not realize that they're supposed to respond better to this? So I think doctors get frustrated because they're wondering, like, why is this person not responding? And so they're basically thinking the person has MDD, which we call major depressive disorder, is MDD. And so doctors think it's this, and it's not. So they keep trying it. They keep doing it. And so, okay, Lexapro doesn't work, we'll try Zoloft. Oh, that doesn't work, we'll try Prozac. Oh, that doesn't work, we'll try. So they keep doing the same thing, expecting a different result from the same treatment, and not stepping back and saying, well, wait a minute, maybe I need to reconsider the diagnosis here. If it's not working, maybe I need to look at this. Are they doing that? No. I mean, why does that statistic pop up? If they're doing that, you're not going to see those shocking numbers about doctors not missing it so often in so many years. And think about all those years of patients suffering. Think about all those years of the severe depression, dysfunction. Because with mania, a lot of people lose their jobs. They get, they get very irritable. They get very moody, and they lose their jobs. They lose relationships. People leave them. Their friends leave them. because they can't take them, because the person is just too difficult to deal with. And so that's the problem. And so I discovered this. So when I heard that years ago, it changed everything. And again, I started really understanding this subject in the 1990s, and this is where the Seroquel came out. And this is actually even before I started switching my practice to full-time psychiatry. And this was in the journey in the 1990s that I was taking as far as figuring out all this stuff. But that conference I went to really, really hit home. And I started looking at everything differently. I started looking at my patients differently. So what do we do then? Now, again, it doesn't mean with these patients that antidepressants aren't going to be needed. They usually are. Okay, there's usually at least one or two antidepressants that the person could be on, but these people are going to be on probably 3 to 4 medications on total, maybe more. A lot of them 4 to 6 medications, sometimes more than that for tough patients. Unipolar patients, which is MDD, major depressive disorder, like anxiety disorders, easier to treat, and that might take 1 or 2, maybe 3 medications. So it's a lot easier to treat, but the difference is with the MDD, with antidepressants, they should respond really well, very well. And then it's very quick to get these people better. So when I see a history like this, or someone comes to see me and I take their history, I know right away that this is a misdiagnosed person, and I can see it the first visit. So now let's say the person is on an antidepressant and they're actually, it's helping. Let's say they say, well, it's gotten me so far, but they tried this, I tried that, I'm not getting any better, this made me worse. So what I'll do is say, okay, well, if that's helping, I'm not going to take it away. That's good. And if the antidepressant isn't making the person manic or in a dangerous state or suicidal, which is, again, another risk with people who are untreated, is suicide. And with bipolar disorder, with the mania, the suicide doesn't usually happen with the mania. The suicide happens with the crash into depression, because the depression with bipolar disorder is deeper and darker than the someone with MDD, or we call unipolar disorder. It's a worse depression, and it's a higher risk of suicidality. So let's say if someone comes in with an antidepressant or so, okay, good, we'll leave it, but they're not getting to our goal. Well, I know that basically what we need to do is put a mood stabilizer in. So there's different types of mood stabilizers, because, with antidepressants, like SSRIs, which work on selective serotonin reuptake inhibitors, they work on serotonin. They attach there because serotonin is leaking. They get serotonin moving this way into the next neuron. Up here. If it's serotonin norepinephrine, we get this one connecting to here. So that's what antidepressants to do. Wellbutrin works on dopamine, so that's going to work on dopamine and a little bit on norepinephrine. So if you've watched my show, you see me talk about these medications and what they do. So if we're seeing, like I said, antidepressants helping, then we can keep them and work on the other thing we'll talk about in a moment here. Now, again, if antidepressants are making them worse, we stop them. If they're not helping, we stop them. If there's no reason to be on something that's not helping, just to be on something. Okay, so what are mood stabilizers? Well, there's the different classes of mood stabilizers. The one that I use the most, or we call the atypical antipsychotic class. There's a lot of them out there: risperidone, Zyprexa, Abilify, Seroquel. There's Sapphirus, Caplyta. I could go on and on. There's a lot of them. Newer ones: Lybalvi, Caplyta. There's a couple of newer interesting medications that I prescribe a lot of. One is called Rexulti, and one is called Vraylar. And you might see TV commercials about those because they do a lot of commercials about them. So these are mild mood stabilizers. So So what I do basically, if it's a more subtle condition where it's not the person's not mania, maybe not hypomania either, they're just still depressed despite antidepressants, then I usually will use like a lighter product. I like Rexulti a lot. It's a very light product. But what it really does is it helps with residual depression and residual anxiety, which is on the I call it the spectrum. So the term I like to use instead of NOS, we call bipolar. I call it bipolar spectrum disorder. I compare it to autistic spectrum disorder. So with autism, you got mild, moderate, severe. You got high functioning. You got low functioning. Same with this subject. With bipolar spectrum, you got very, very mild. You got more moderate. You got more severe. A lot of my patients are more the mild to moderate stage, and Rexulti is a good one. Vraylar is a good one too. Now, when they market, they're marketing basically as we call augmentation with an antidepressant. Now, what that means is they're marketing to say you add us to an antidepressant and we'll get the person completely better, much better. Much better means we call it remission. In this field we call that remission. So with Rexulti, if someone gets to hear that person can get much better very quickly, actually. But when they market it like that, it's really false advertising. It's really not what it's marketing. It's not really MDD like they say it is. And they say, well, it's treatment-resistant depression. Okay, well, that's what they call it. What does that mean? It means it's not responding to antidepressants. Well, why is that? Because it's not unipolar depression. It's not MDD. It's bipolar depression. It's a much more mild variation than 1 or 2. It's in the NOS area, but it's probably on the low spectrum of NOS. And so with these patients, just a little bit of something like that, they can get much better very quickly. Now, what those are, and we call and again, when I say atypical antipsychotic, it scares people away a little bit because I'm not psychotic. No, you're not psychotic. You don't have schizophrenia. So the problem is when people look these up, they get a little bit afraid because it doesn't. They say, well, it says. I know it, but well, you think I'm psychotic? No, I don't. So it takes sometimes explaining, like, no, that's not what I'm doing. So the fact that they market that way, it's kind of good in certain ways because it doesn't scare people away as much. It's a little bit more friendly. But the problem is that if doctors don't understand this and they don't understand why they're adding Rexulti or Vraylar, they're not going to really understand this subject very well, and they won't. And especially primary care doctors get afraid. But the reason they market it this way, they don't say it, but it's the truth, is they don't want to scare away doctors. They want primary care doctors to feel more comfortable. And if they say adding to an antidepressant, they don't say what I call the B word, bipolar, then they think, well, doctors are going to be more comfortable doing this. And it's true, they do. But family doctors, by and large, are not comfortable with anything besides antidepressants. Most of them. That's just a fact. And to be frank about psychiatrists, not to disparage them, but sometimes they're not that much better because they don't really understand this very well either. Sometimes. I'm not all of them. Okay, but a lot of them. So what's the difference? What's this class do? It's called dopamine antagonists. See, like Wellbutrin, it takes dopamine and it just boom, it gets it moving forward. And what's good about that? Wellbutrin, motivation, energy, focus. So Rexulti, the Vraylar, we call dopamine antagonists. What does that mean? It slows dopamine down. So when you get a combination of antidepressants going this way, sometimes it's too much. Sometimes if you want to, it's good in a certain way, but if we don't put a brake on things, we call it modulating the chemical. Which if we don't kind of fine tune these things, then it's just it'll help, but then people will get worse, or they don't get completely better. So basically, something like Rexulti will slow it down when it needs to slow down. It'll increase it when it needs to. It's kind of like putting a dimmer switch on the light. You turn it up when you want it up, you turn it down when you want it down. And here's the other thing about the marketing of Rexulti, okay? So the dosing of major depressive disorder, we call augmentation or treatment-resistant depression, whatever you want to call it, is from 1 to 3 milligrams. 4 milligrams, they target it, they market it for schizophrenia. So think about that, and I talk about this when I go to like a lecture and I ask and the doctor is lecturing about it, I ask them, they don't have a good answer for me. I say, you mean 1 milligram away from depression and schizophrenia? Well, they'll try to reason with, well, the studies were taught, we didn't study it for that. Yeah, study. So the studies aren't, the pharmaceutical companies will market, they'll study things the way they want to study them to get them approved for a certain indication. That's what they do. And so, I'm fine with that if doctors will just do it and follow through with it. But again, a lot of doctors won't do it because if they know it's in a certain class of medication, they just won't do it anyway. But some will, which is good. So that's what's going on here is that it's, we want to, and with bipolar disorder, the main key chemicals are dopamine and GABA, or GABA and glutamate. So the two main classes, and again, before I talk about that, so Vraylar, the same thing, 1.5 milligram for this, up to maybe 3 milligrams, 6 milligram like schizophrenia, 3 to 4.5 milligram bipolar disorder, 1.5 milligram major depressive disorder. It makes no sense. So why, it's the same medication, but you're just saying that change the dose and it's a whole different indication. It makes absolutely no sense. I mean, it does make sense, the fact that you go up on the dose to treat more difficult things, like if someone who has a higher grade of bipolar disorder, yeah, you're going to need to go up above 1.5 most likely. And with Rexulti, you might have to go to 3 or 4 milligrams, But usually, most of my patients with Rexulti are 1 to 2 milligrams. That's a pretty average dose. So those are the dopamine. What the other class of for bipolar disorder is the GABA. I call the GABA class. Okay, you've got Depakote. So there's also we call the traditional mood stabilizer. You've heard of lithium, I'm sure, and Depakote. So lithium and Depakote we call the classic mood stabilizers. They've been around a long time. The problem with, I don't use them first line because, they might have more side effects. They need blood monitoring occasionally to make sure the kidneys and liver are fine and make sure the thyroid is fine. But Depakote is a great medication for certain people. But what that does is actually, it's not blocking dopamine like that, like the atypicals do. It actually improves the flow of GABA. It improves GABA and suppresses glutamate. So GABA and glutamate are kind of opposites of the same chemical. Basically, glutamate stimulates the system and GABA calms the system. So if you have a medication that either increases GABA or suppresses glutamate, it has the calming effect on the brain. And that's what these do. Depakote, trileptal, Tegretol. You might have heard of the medication gabapentin. Gabapentin is in the same family. Topamax is in the same family. And these are very mild medications, except Depakote's a little bit heavier for more the higher bipolar patients. But a lot of these very, very subtle, there's so many subtle variations in this. I use a ton of Topamax. The advantage of Topamax is you get weight loss, you get anxiety reduction, you get pain reduction in your body. It gets rid of headaches, gets rid of pain. Gabapentin is fantastic. Anxiety reduction, pain reduction, but you don't get the weight loss. So every medication is different, but that's what we're trying to do here is we're trying to balance the nervous system properly. It takes understanding this. It takes that you have to put medications together. You can't do 1 or 2 medications. It's just not going to work that way. Most of the time, people are on about probably 2 antidepressants, maybe 1, but usually 2, and maybe a couple different mood stabilizers. Maybe an atypical with dopamine agent, maybe a GABA agent added on, maybe two of the atypicals together, because sometimes one of them, like Seroquel, is great for sleep, but if you try to go too high, it's too sedating the next day. So you get it to what the patient can tolerate, then I might add some Abilify in or something else. It's a different one, and sometimes you put two together. So it's just a lot of, you have to be really creative in this field of medicine. You have to really understand how you mix things together, and that's what I love doing it. I love the challenge of it, and it's exciting to me to see the results when people are better and how far they've gone in such a short period of time. And so, relatively short period of time, and especially the people who've been suffering like this, like if they've been seeing doctors and they're stuck in this mode of just the doctor's not diagnosing, not treating correctly. It's so common, and it's so many people out there that are suffering needlessly and don't have to. And that's what drives me to do what I do, is because my mission is to change that and to educate and to get people to understand that no matter how difficult your situation is, there's a solution here. And people might say, well, it's too many medications. I'm not a pill person. Well, you got to get rid of that thinking. You got to understand that this is a medical problem. It's a neurological problem. You can't help it. It's genetics. If someone's bipolar, any version of it, it runs in the family. Mom or dad had it, siblings. It's genetic. It has hormone changes don't help the situation, like menopause or after having children or puberty. Stress and trauma doesn't help the situation. But once you identify it and realize that this is a medical problem, it's not a psychological issue. You can see a therapist, but they're not going to fix they're not going to fix this. Over-the-counter herbs and supplements are not going to fix this. You need serious medications that are actually going to fix the problem. And if people get stuck into I don't want to take a medication and I'm not a pill person, it's not a good place to be at, because you're never going to get this better. And if you don't treat this and get it better, it won't treat itself. It'll get worse over time, and all that suffering is for nothing, because there's no reason for it. So am I hoping that this is going to change someday? I sure am hopeful. If people understood like how ridiculous those numbers are, taking this long and this many doctors, really? I mean, aren't one of those doctors going to say, wait a minute here, why do we keep doing this? Why is this not working? Well, you have to step back and say, well, it's not working because the diagnosis isn't correct. And if the diagnosis isn't correct, then how are you going to treat it correctly? So you have to have the right diagnosis. In this field of medicine, it's not easy. Like, you don't do a blood test to find out. You have to listen to your patients, take a good history, and be very open. You have to be a good listener. Doctors are really good at talking, but we're not. A lot of us aren't good at listening. And in this field, you have to do that and to make this work. So, I hope this is helpful for you. If you have any questions about this, by the way, feel free to contact me. And if you want if you know anyone that needs help, send them to my office. I do a lot of virtual visits from people who don't live in my area. So I'm open to seeing people and treating them if someone needs help. And often the case of people need help and they just can't find someone to help them. In that case, you have to go to someone who knows what they're doing. So anyways, thanks for listening.